70-year-old myelopathy and neck pain. T1, T2, axial. And so what's the diagnosis? Do you think it's disc protrusions, it's cervical spondylosis, OPLL, dish, or ankylosing spondylitis? And the answer is OPLL. Excellent. That is the correct choice. And I was ever so kind because I gave you the axial view. I'm sure the tests, first of all, they always show OPLL at all these tests. I have yet to see one that doesn't have it. It's one of these index cases. And they always withhold the axial. So you got to, again, the key thing is that disparity of T1 and T2, that low signal that you miss on the T1, but you can only see carefully looking at the T2 to make sure that difference between where the CSF is at and where the real vertebral body starts. So that change and that low signal in between is where they always get you and hold back the axial. So OPLL, and of course we like to have something that really shows that it's calcium. Here's the CT view. You can have wide variety of signal from the OPLL. It can be jet black on all pulse sequences if it's just really bone, although if it's there long enough over multiple segments, you can also have marrow within it, so you can have a lot of fairly high signal on T1 as well. Just examples of cervical spondy, multiple degenerative disc disease. I kind of classify this as the dish cervical spondy categorization with these exuberant ventral osteophytes, every level badly degenerated, as well as these sort of disc osteophyte complexes smashing the cord at a couple levels. Look for the high signal within the cord for the contusion, the myelomalacia. Each of these cases has that. So let's think about OPLL. The following is true of OPLL, except patients tend to present later, 6th decade. They're generally older than the usual disc disease patient, but yet younger than cervical spondylosis. Presenting complaints are neck pain, dysesthesias, extremity weakness, and the surgical approach primarily anterior multi-level corpectomy and strut graft. Your answer. I do know the words to that song, but I'm not going to. That's misspent youth. Thanks. So the bulk of you are going to say that this is incorrect to say cervical approach primarily anterior multi-level corpectomy and strut graft. That is the correct answer. That is not the correct answer. These are true. Really the primary, you may see anterior discectomy. They may take it out, but I think the key thing is to recognize the entity, because the surgeons will be very unhappy if they don't recognize this entity and go in and come up to this big wad of bone in the epidural space. They're not going to decompress the patient. So a lot of this surgery is done by, and this is the trapdoor laminoplasty approach, multi-level, hinging open from a posterior approach to give the cord room, but they're not really trying to take out or remove the OPLL. So the answer really is, posterior disease is one of the unusual causes for doing posterior approach in the cervical spine. Next one.